started here first. So for those of you that are on, I'd like to introduce you to Ricky from R3 Integrative Health. I had the pleasure of meeting Ricky right before COVID-19 all happened and we had to shut down. He was doing a live presentation here in Moncton. And I will tell you, I was absolutely blown away by some of the work that he does and how he helps people. So I was chomping at the bit, waiting for the presentation to get over so I could ask him if he would come to my clinic and also do a presentation. And then, COVID happened, so we moved it online. So I'm really happy to have Ricky join us tonight and share with you what he does. And with that, Ricky, I'm going to pass it over to you.
Perfect. Well, thank you for the introduction there. That's great. Yeah, it's unfortunate about the COVID-19 situation, of course, because there's so many things planned, so many possibilities happening, right? So, no, I met you there at the talk at Kuma Yoga. It was a nice little presentation. That was actually my second one I've done. And no, what I'm going to be talking about today in general is functional neurology. So it's not your typical doctor of neurology. It's more so looking at the function of the human body, not on a disease basis, but on a how can we make your nervous system more efficient basis. So looking at people's deficits, quote unquote, even if you take someone's reflexes and their leg doesn't kick, like when you go to the doctors, they take your reflexes. There could be things that are really blatant that you can actually help without having to give people medicine or surgery, all kinds of neurology talk there. So the functional neurology is an umbrella term in the States. They actually call it chiropractic neurology, and you have to go to chiropractic college and then go through postgraduate education to become a board certified chiropractic neurologist. Now in Canada, you do not have any kind of title like that. So no matter who you are in Canada, you can actually practice quote unquote functional neurology. It's not by any means a type of profession or anything. It's just a method or style or approach to conservative healthcare or manual therapy, right? So physio, chiropractor, osteopath, massage therapist like myself, anybody who has a manual therapy title, who is in good licensure with a governing body to touch people and have liability insurance to touch people can practice it, as long as they have sufficient training in it and are safe doing it. Even though you can't really hurt somebody doing this type of work, it's very very small little changes that are happening that really affect things on a big scale in the rehabilitation process after an injury or chronic pain, whatever have you. It's just really cool, and it's a different approach that not too many people around here implement. So what I'm going to be really talking about today, for the most part, is a bunch of different concepts within the umbrella. Essentially a little bit of a breakdown of the nervous system as a whole, the different sections of the nervous system, and I'll give analogies as to what they are. I'm going to go over a few whiteboard presentations that I have in a presentation I'm actually going to switch my screen to. I'm going to talk about different experiences I've had with patients, just to give a little bit of background and context to what I am saying. I'm going to blab on about some theory. I'm going to talk about how the theories make sense in a practical setting in real life. So I'm going to say things in very sciencey terms and kind of translate them into English, so to speak. There's a lot of jargon there. Neurology in itself is very, very daunting. It's a very dense subject. There's a lot of stuff going on there. So for the purpose of people listening, I want to kind of not dumb down the information, but make it more digestible in a way that makes sense and applicable to everyday life. So are there any questions for me before I get started? I figured I'd ask that just in case. If there are none, I'll just switch my screen. I'll wait a couple seconds here. Feel free to just type that in the comments, and I'll just wait a couple seconds if we don't get any here. Awesome. So I'll go on a whim and say that I'll just start up then. So just interrupt me, Catherine, if there's anything, okay?
Yeah, I will. I'll keep an eye to it. No problem.
All right. So do you see the presentation on the screen? There we go. Start this up.
Yes, I do. Sorry, Ricky, I was on mute.
No problem. You should be able to see this red dot flying around here. So I'll be resorting to this dot. All right. So this is a brain. Kind of looks like a circuit. So it's going to be diving into why it looks like a circuit. I'll be diving into that shortly here. So we're going to go into this. So the goal for today is to do deep dive into functional neurology as a whole. Again, I'm not the be all end all resource on this topic. I just practice it all the time. I find it's very valuable. Here, as you can see, I'm holding someone's feet on one end. I'm doing a manual muscle test here. I'm pulling their legs towards me while I'm actually touching one of the muscles of the hip up at the top. That's a very common thing. So when you touch a muscle like that or any area of the body, it's called a therapy localization, or short TL. It's just an abbreviated term. So when you touch something, you can make a change in a muscle test. So that's all you're looking for, is a muscle test going weak to strong or strong to weak, or some gross change to happen in the body when you touch an area. So the goal for today is to kind of dissect functional neurology and the brain and how it works on a functional basis, more like comparing it to a computer. So I'm going to go into that here. So I've been practicing since 2017. R3, my clinic, stands for Restore, Rebuild, Resolve, massage therapy at first. Now it just turned to R3. It was a longer name. So I practice Grafton technique. So that's these metal rods that you use to scrape tissues with. It breaks down scar tissue and adhesions in between and over the surface of muscles. I practice neurokinetic therapy, which is a neuromuscular technique, which really is what got me into functional neurology in the beginning. Really, really cool stuff. And that's actually what you were seeing me, whoops, let's go back here. What I was doing here is actually neurokinetic therapy. So that's just putting that together. So PDTR is kind of, to describe it briefly, is neurokinetic therapy on steroids. That's the best way to describe it for it to make sense. It is just way more robust of a system altogether. Neurokinetic therapy serves as a prerequisite, in my opinion, to PDTR. So that is more of a robust system of analysis and treatment of all those neurological dysfunctions or neurological signaling errors in the nervous system. And then I put osteopathy here because I'm actually a student of osteopathy. I'm in my second year of 5. I do functional neurology as well. So that, of course, is an umbrella term. It includes the neurokinetic therapy and PDTR and a few other techniques I've kind of developed along the way, mixing things together and seeing common things and using them because they work on a regular basis. So where we're at today with patients. So people in general are on more drugs. They're having more surgeries. People are heavier, sicker than ever before. And people are actually thinking that drugs and surgery are the only answer for their chronic pain. So people usually resort to drugs and surgery when there's no other answers for anything. When physical therapy, massage therapy, chiropractic, osteopathy, acupuncture, psychotherapy, everything has not worked, or they've been put into this category where they can't find any solutions to their issues and they feel stuck. So they resort to drugs and surgery, right? That's kind of their last hope. So the general philosophies that I kind of always abide by is I always try to ask why the body is doing what it's doing, right? What is it trying to accomplish by doing what it's doing here? So the body and Mother Nature is extremely, extremely robust. And there's a lot of things that are intended to happen there. So you have to really respect what the body's doing and it's trying to tell you something. So instead of suppressing the system with, let's say, medicine or cutting something out with surgery, it could be a very valuable tool to kind of see, okay, interpret what the body's saying and give it what it wants instead of cutting something out or modifying the body's physiology another way. So healers of all professions, they want to help people, right? So no matter who you are, what profession you are, you want to try and have as many tools in your toolbox as possible to address as many problems as possible. A lot of people try to give, they try to accomplish every task with a more of a cookie cutter approach. There's a lot of people who do this, and a lot of people miss a lot of things. And what I mean by people is different practitioners of manual therapy. So we've all heard of certain professions maybe having a bad rap for certain people in certain professions doing things a certain way, right? And putting people through the machine, as I would call it, or just the cookie cutter approach, trying to fit everyone through that mold and not really molding it to the patient, the individual patient. So my approach is very individual and it changes from visit to visit, depending on what the nervous system or body is saying, just like I said in the first paragraph. So the more tools you have in your toolbox, the more people, the more problems, the more issues you can resolve, in my opinion. So this is a picture here of someone grasping the lower back. And this was intended for a live presentation where I actually would demo somebody with lower back pain. 80% of adults have lower back pain or will have lower back pain in their life. That's a US statistic. So there's a lot of people with lower back pain. So what I typically do is I get somebody on a table right here and I demonstrate if they said they had lower back pain. I try to do a few muscle tests. And very typically, I want to say 95% of the time, there are a certain group of muscles that I test and they are very weak. The person may not necessarily be quote unquote weak, but their nervous system can't utilize those muscles or control them efficiently. So there's an inefficiency in the musculature that I'm trying to test. It's kind of like the brain and spinal cord are the cell phone signal, or the cell phone tower, I should say. And the muscles are all the cell phones. Think about it, it's the bell tower and you have bad service on your telephone and you can't make a call. That's kind of what's happening to these individual muscles remotely from the nervous system. So if there's poor connectivity, there's poor activation of those muscles, you're going to have some instability perhaps in that area, and then other muscles around the area or on the opposite side of that area, say hip flexors in the front, in the lower back case, they'll compensate and they'll overwork to accomplish the task. So your brain needs to get your brain knows that you need to get from point A to point B some way, somehow. So let's say your lower back muscles, let's say these guys right here, the long spinal erector muscles, they're enormous. They go from the base of your cranium all the way to your tailbone on both sides. Now, what if they are weak or quote unquote not firing right? Other muscles around the area, maybe your oblique muscles on the side, your hip flexors on the other side here, your glute muscles, the deep glute muscles, your hamstrings down below, they may all compensate and get really tight and rigid, and that may appear as, oh, I can't touch my toes because of the instability that's actually happening in the lower back. So your brain might read that as, oh, the lower back's unstable because these lower back muscles are weak. So all these other muscles got to get really tight to protect the area and also try to get the person from point A to point B somehow, right? Even though it's not efficient, it has to happen. So when you run an inefficient pattern for so long, you start to get problems. Now you can start seeing my logic here. So pain in general. So this is a theory. This is called the gate control theory of pain. So this is, I believe it was a chiropractor who discovered this or developed this. Essentially, it looks at the pain gateway to the brain. So you have over here on the side, I'm going to highlight this, sorry. I'm going to go back here. On the side here, we have a brain. We have, here is the gateway to pain right here. So if it reaches this little bubble, you feel pain. You feel pain. You feel pain. So we have small and large fibers, right? If there is no input from either one of them, you don't feel pain. The gate is closed. So this P is the big gate here. So what happens is a stimulus will go in through the sensory nerve endings, let's say on the surface of your skin. Let's say someone touches your arm. Okay, that goes into the nerve endings and it sends a signal all the way up the spinal cord into the brain. It gets processed, and then that pain gets sent out through motor pathways back to the area, and that's eventually how you feel the pain. So in this case, let's say the large fiber is sending an input to the brain. It's going up the spinal cord into the brain, and what's happening is, follow this little red dot, it goes into here where this plus sign is, and what it does, it actually stimulates this here, right? That closes the gate. So you get a large fiber like that sending information to the brain. It also stimulates this inhibitory neuron right in between. So that inhibitory neuron, that's what the I stands for, closes this pain gate. It closes it so that there's no pain fibers that can cause pain at this time. Whereas here, there's none happening. This is not getting inhibited, but there's nothing coming in here. On the flip side, if you get a small, they call it a small fiber input, this actually turns off the inhibitory neuron, and this remains open so that when you get this type of stimulus, it goes directly into the brain to the part where it actually interprets this as a pain signal. So big picture here, the large fiber is more mechanoreceptors. Mechanoreceptors as a whole are movement and stretch and pressure receptors. So if you take your skin, you take your hand and you put it on the surface of your forearm and you stretch it back and forth, side to side, you can feel your skin stretch there. This would be a large fiber input. If you go out for a walk and all those stretching and the pressure and the movement, all the ligaments and muscles and fascia moving, you're putting in a lot of this input, right? So you're actually inhibiting the pain pathway by doing movement. This makes sense when you start to think of why physiotherapists make people move in an early part of the stage of rehabilitation. Usually general movement, like going for a walk, it's low impact, so it's safe on the joints, and it's very, very low load on the nervous system as a whole. So walking is a great thing for not only circulating the blood flow, cardiovascular health, but also trying to mitigate some of the pain. Whereas if you just get something like someone slapping you on the forearm, when someone slaps you on the forearm, there could be actual cells that get split open on a microscopic level. What was inside of those cells gets sent out of the cell. Your body realizes that because there's like potassium ions and cytokines and certain things that are living within the cell that get picked up by your immune system and say, whoa, 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 there's damage here. It's picking up damage or a potential threat. And it sends an actual signal which inhibits this gate inhibitory neuron. The gate remains open, so pain eventually gets there. Now, when we let's say we hit ourselves on the head, what do we do usually? Well, you either grab your head or you rub your head really hard. That's usually a normal thing. Or if you cut yourself, you squeeze it. That is a perfect example of this theory right here. So in theory, it's okay. What you're doing is something's happening. You're receiving some damage and your brain is perceiving it as a threat, giving you the pain to make you aware of it. And then what you do to mitigate the pain, it actually makes it feel better if you rub it, is this here, this large fiber input that you're bringing into the brain. So that should make sense. I know this whole chart is pretty daunting when you look at it, but when I break it down like that, it starts to make more sense. So getting someone to move in the rehabilitation process is very, very, very powerful. It's usually underlooked by a lot of therapists. Like usually massage therapy, we're deemed passive care because a patient or client walks in the room, okay, they discuss briefly, this is a generalization, of course, they discuss briefly what they want, and then you get them on the table, and you massage them for an hour, and they leave. That's passive. They didn't have to do anything there, right? Ideally, what you would like to have, in my world, get someone in, you have them move, you see where their movement's faulty, you get them on the table, do a few maneuvers, make sure that you can restore some of that mobility, and then get them doing it as soon as possible. That way you put the ball in their field, but you also get them moving, which may increase your pain reduction kind of approach that much better. So this slide here is the nervous system overview of the CNS, which is the central nervous system, which is the brain and spinal cord, and the peripheral nervous system, which is the sensory and motor divisions of the peripheral nervous system. So two main ones, the central nervous system, brain and spinal cord, that is like the processor of the nervous system. That receives and interprets and sends out signals to the entire nervous system and from the entire nervous system. So that is pretty, that's pretty basic. That's your motherboard of your computer, so to speak. So we got the peripheral nervous system here on the side, which is, again, sensory and motor. If we go to sensory first, so we have our senses. We have 5 senses. They're all specialized. Those are the ones that are typically around the head and face. If you haven't realized that, your sense of hear, smell, taste, vision, it's all in your face. And then touch, of course. Touch gets that's the more general one. It's touch and sensation. It gets divided between in the general category of somatic and visceral. Somatic being the bones, muscles, skin, those tissues on the outside of the skeleton and the skeleton itself. The visceral being the actual organs, which actually have their own kind of highways or pathways to the brain separate to all those other ones in the somatic. That's why, so the somatic, all the muscles, all the tendons, all the bones, they have a different kind of pain presentation than what an organ does. Someone comes in with, like, let's say a stomach ulcer type pain, they can't really pinpoint where that is. However, if someone sprains a ligament, they know exactly where they're feeling that. It's not really a diffuse type of pain. It's kind of really specific. Like you tear a muscle or you pull a muscle or you strain a muscle, you can usually feel exactly where that is, and it burns, it pinches, you get off of it. But usually something visceral, very typically, isn't really pinpointable. It's a general area, and so that there describes how different pathways act differently, and the final result of what is being interpreted as pain is coming from a different source. That's how you kind of determine where it's coming from. Not always correct, but it's pretty 95% of the time it's pretty one or the other, pretty obvious. So that covers the general and specialized. Now, when you see this in red, this in red down here, the sensory receptors, that's what I was talking about when I say somatic and visceral. The sensory receptors is what I work with. Doing the PDTR, neurokinetic therapy, functional neurology, quote unquote, we're actually working with sensory receptors. Now we're going to get into more detail of what they are, how they matter in the grand scheme when I go over an analogy comparing it to a computer later on. So we'll leave that for now. We're going to move over to the motor side over here. So we got our motor. Here we get somatic, which is voluntary control, or autonomic, which is involuntary control. So you get really, really, really scared, and your palms and the backs of your knees and your face starts sweating because you're stressed out. Okay, that's an autonomic response. You can't control that. Or you get really, really scared once again, and your heart starts going quicker. That's involuntary. That's your autonomic nervous system, right? Fight or flight. So that's parasympathetic, rest and digest, and the sympathetic, fight or flight. You're getting chased by a tiger, or you just eaten and you have to relax and digest something, right? Or sleep, or whatever the case, the very opposite. They're polar opposites. So on the other side, you get somatic voluntary movement. That's the kind of stuff where I would try to modify. So by dealing with these sensory receptors, we're really trying to get this voluntary movement to get better. So you're not voluntarily moving poorly. Your brain just figured out a better way, or a way to get something done from point A to point B once again in a very inefficient manner. That's why you've come into my office, and we're trying to make this more robust. So when you raise your arm in the air, you're actually using the correct muscles to do it, to accomplish the task. So you don't run into issues, or if you've run into an issue, we got to backtrack you a little bit. We can actually bring you back to a baseline of normal. So that concludes this. We're going to go on to the next one. This is exactly what I was talking about when I mentioned the computer analogy. So this is actually pretty simple once you break it down. So a computer, it has software and hardware. Hardware's on the outside. It's the screen, the monitor, the keyboard, the mouse, right? All the stuff that is replaceable. Then you have the software within the computer, how it's actually functioning, right? How it's actually, how it's processing things, outputting things, receiving input, all that stuff, how it works. And then if you get some software developer, if you get a problem with your software, they go in there and they write some codes. And what was once an error becomes something that actually works now. That's a software problem or software solution, right? So very generally, breaking it down to categories of how it works now, you receive input, which is sensory receptors, like I said, and pathways. So sensory receptors are nerve endings all around your body, at the surface of your skin, in between joints. A lot of them are in between joints, sensing stretch and rate of contraction, rate of stretch. You have pathways, which are basically nerve ending has to get to the brain somehow. That's all those pathways, right? That's the highway that all that information coming in from the nerve ending, all the nerve endings, it goes to the brain through these pathways. So the processor, once again, is the brain and brain stem, the central nervous system. Everything goes into the brain and the brain stem for processing. It goes in there and the brain's like, okay, what is this? Is this threatening? Is this not? What do I have to then send out through the output to get the job done? Where do I have to send the signal? Which organ, which part of the body, which part of the brain do I have to relay this to? An old skill that I've learned when I was, let's say, 3 years old, when I started running and throwing balls and all that stuff. What do I have to recollect and then send it out to the body to make it happen, right? So the output is, let's say you browse a Google Translate or a Google pronunciation of a word. You click on that word. You sending that input of the click goes into the processor, and the brain, or the computer, the brain of the computer interprets that as a click. You click on the icon and it starts spitting out the words. That's the output, right? Through the speakers, but it actually has an output to tell the speakers what to do, right? So that is the way the software operates. Now, if you have a hardware issue, that's your bones, organs, muscles, tendons, everything that's hardware, fixable by surgery, right? So if you have an actual, let's say you break your bone, well, the software is going to have to change a little bit afterwards. You're going to walk funny if you sprain an ankle. Eventually, you're going to, put more weight on that foot if you properly rehab it. But you're always going to have a bit of software dysfunction where you actually tore that tendon or ruptured that ligament or whatever have you, strained a muscle, right? Or broken a bone. Your system's going to rev up the area that you damaged just for protective means. So it's going to try and protect you from the area. Now that's pretty normal, but it should only protect you from the area while it's healing, and then it should go back to normal. Once it's been 6 months and you haven't had any, let's say you've gone 6 months and you haven't had any symptoms, you're good. Everything's healed after 6 months. That's the general rule. So it's been 6 months, and then you start doing, you start jogging again, where you jogged before, let's say years ago, and you sprain your ankle. 6 months later, you want to jog again because you're so happy that you have your foot back. Then you notice a few weeks later that you're starting to get some hip pain on the side, the same side that you sprained your ankle. Okay, potentially, this is actually very common. Maybe some of the tendons and ligaments, right, that were damaged are still being protected, overprotected by the nervous system. So the sensory receptors that are local to the tendons and the muscles and the ligaments that you damaged or traumatized are sending too much information to the brain. That's getting interpreted as, oh no, this is dangerous, potentially. What we're going to do is we're going to change the way the muscles are firing in order to protect this stuff again, or maintain the protective mechanism, right? So this becomes a software issue now, where you're stuck in this endless loop. Even though the hardware is completely healed, the muscles, tendons, and joints are still behaving as if you're still injured. Now that's a software error. That's when the programmer has to go in and do some coding work to make sure that error doesn't come up again. But that doesn't always come up as a symptom. You may have absolutely no symptoms. You may only have symptoms when you start pushing your body, and it might be too late. Not trying to fearmonger or anything, but it's usually, you're not going to feel it very much. Sometimes you do, and you go in, there's something off, usually an athlete or something. Yeah, I'm just not moving right. I feel stiff. Something feels off. What is it? I always ask for history of injuries. Ankle sprains really, really mess with people's sense of balance. Not only the sense of balance, but where your brain thinks it is in space. You may put more body weight on the side you didn't sprain. Just like when you initially sprain it, you're going to have to, take some weight off of it. Some people go as far as going into crutches or a boot if it's really bad. But if you just sprain your ankle a little bit, you're going to be putting a little bit more body weight on the opposite side to heal the other side. Even if for a few days or so, it might not bruise or anything, but you might actually have an issue develop. So that's a perfect example of this. So working with hardware, like I said, on this side, this is a physiotherapist or chiropractor doing a manipulation to the pelvis here, probably the sacroiliac joint or lumbar spine, by the looks of it, probably the iliac or the sacroiliac joint. That's where your sacrum meets your ilium. So what they're doing is they're actually they're working with the hardware. I call that a hardware thing because some of them argue that you're actually changing the hardware. Some argue that you don't. What I'm just saying is they're working with the bones and the ligaments, trying to realign them manually by manipulation. For those who aren't aware, that's when a chiropractor cracks your back. So when you look at this side, this is an actual hip replacement. It kind of looks like a doorknob where they actually take the acetabulum, not the acetabulum, but the head of the femur, and what they do is cut off the femur, whether it's dead or not. They jam a rod, could be titanium or any other kind of metal, and then they replace the actual hip joint and the socket. That is a hardware issue. That is only replaceable by surgery, and then once it's the hardware is replaced, the software has to kind of permanently change to accommodate this, right? So that's another situation. When working with hardware, you might have, let's say you might have a scar here where the surgery took place. I might have to work on that in a hardware, quote unquote, hardware approach, where I take the Grafton technique. I take my thumbs and I dig through the scar tissue with some oil to try to break it off the adhesions here. So that might be a process of the rehab, a part of the rehab process in this patient. So obviously, the hardware and the software kind of go together. You cannot separate them. They're two entities that will remain. It's kind of like they're principles, right? You can't avoid there being hardware, you can't avoid there being software. They kind of interplay together. They're black and white. So this is where I do a hardware demonstration. Usually I'd get an unlucky person on the table and I would dig my thumbs into somewhere that really hurt. Not to hurt them, of course, but to get in there and actually demonstrate a before and after. I demonstrate someone who has poor range of motion, let's say in a shoulder, and then I do some active compressive movements with digging my thumb into an area, having them move and stretch it out while my thumb's dug in, and do it a few times just to show some immediate kind of effects. So sometimes some people have hardware issues like an old ankle sprain, and they have muscles built up with scar tissue because of that as well. Maybe the ankle wasn't addressed or something like that. So over time, you develop adhesions or scar tissue in muscles where, let's say you sprain your ankle. Once again, let's go on that same analogy. You sprain your ankle, the muscles around the joint contract, they stay contracted, and they're in a state of what's called spasm, right? A muscle spasm. And what happens is if that muscle spasm is prolonged for a long time, you get a lack of oxygen in that muscle. So if you think about it, let's take an analogy again. You take a sponge and you drop it, you put it with your hands, you hold it and you put it into a bucket of water. The water is going to be absorbed into the sponge immediately. Now, if you take that same sponge, you take it out, you wring it out, but you squeeze it as hard as you can in your hand and then put it in the water, not much is going to go into that sponge, right? So there's going to be an altered amount of blood flow, and the blood is what carries the oxygen. So when that happens, the deficit of oxygen over time, what it does, it creates an environment that's more acidic. The pH goes down, right? More towards the acidic side. And then your brain reads that as not good, of course. What it does, it inflames the muscle. And then over the course of time, since there's inflammation there, the body's natural instinct is to try and rebuild that muscle because all those little cells and proliferation cells are in that area anyway. What they're going to do, they're going to try and reinforce and build that muscle on top of the muscle spasm. So you might get excess. It's just like when you get a scar on the surface of your skin. It's kind of like that same connective tissue. It's like glue in between your muscles and whatever nerves are nearby, other muscles, muscle to bone, it doesn't matter. Scar tissue doesn't care. It's on all directions. It's like a big spider web of goo holding everything together. That's kind of what develops. And that's what I really refer to when I mean hardware. You got to address adhesions. They're a real thing. There are surgeries out there where, let's say for sciatica, for example, they cut you open in your gluteal muscles and they relieve pressure on the sciatic nerve. What they do is they cut adhesions out of there, right? There's people who develop carpal tunnel, and there's a ligament in your wrist that they have to snip open and remove any pressure that's pressing on the nerve, giving you those symptoms in your hand. Same thing. It's a hardware thing. Sometimes it's too far gone. It needs surgery. Sometimes it can be conservatively managed. So that's the hardware. It has nothing to do with functional neurology, but see how it can affect your software or your neurology. It can totally affect it. So it can be chicken or the egg here. So working with software. On the left-hand side, you see a man in a blue shirt testing a shirtless man with a watch on. He's pushing down on a muscle, and the person sitting down is resisting upward. He's doing a muscle test on him. So that man is, his name is Dr. Jose Palomar. He developed PDTR, one of the techniques I actually practice. And he is an orthopedic surgeon from Mexico. Brilliant guy. He basically developed the PDTR protocols, and to put it simple, he figured out the logic of the nervous system and how to kind of how to manipulate the nervous system in a way to achieve a really fantastic result in very, very little time. It's just very difficult to learn his technique, PDTR, because there's so much to it. It's very nuanced. There's a lot of little details to it. But if you look here on the right-hand side, it doesn't say anywhere in the picture, but it's actually, it represents applied kinesiology, AK for short. He was an applied kinesiology. He was a diplomate in applied kinesiology. I don't know for how long, but I believe it's over 15 years. I mean, he's been a surgeon for a very long time. And he's been practicing applied kinesiology for a very long time. So at this point, he doesn't do much surgery. He used to do a lot of surgery. He's an orthopedic surgeon, and now he doesn't do very much surgery because of PDTR. So that's his story there, and why he uses it, because there's a lot of times where you just do not need it, right? You don't need surgery. You can conservatively manage a lot of things, and now he uses it. So applied kinesiology as a whole, you look at nerves, you look at neurolymphatics, you look at neurovascular stuff, you look at cranials, which is your cranium or your head bones, all the bones of your skull, how they interplay with things, and how how a misalignment or a fixation of one cranial bone, there's many of them, how a fixation of a cranial bone can affect different systems of the body. They look at acupuncture meridians. So whether you put a needle in somebody or not, you access points with touch. You address nutrition, which is a big one too. So you look at how biochemically someone could be affected on a nervous system basis. You look at the mental health aspect. You look at the structure, which is the function, once again, the hardware, which is the structure. You look at all kinds of different things, and you add them all up into this huge, huge approach, which is called applied kinesiology. And then PDTR kind of simplified all of that and added to it. So PDTR is kind of like a continuation or an update to applied kinesiology in the offices of a manual therapist. It makes everything very simple. So applied kinesiology is very, very difficult in my opinion. There's a lot of moving parts, and PDTR really simplifies and streamlines it. So again, PDTR here on the left side, that's the logo for it. Down on the right-hand bottom side is a patient lying on the table with the clinician or whoever, they're doing shockwave therapy. I actually have one of these units in my office. It actually is an air compressor in the gun looking thing, there's a tube in it with a metal pellet that goes back and forth. And on the end piece, that black end piece that's in contact with the patient, there's another metal end piece there. And the inside metal piece, it's like this little bullet. It gets shot and it hits the end piece. And that kinetic energy, if you think about you have the balls on strings and you let one go and it hits the other ball, and the kinetic energy makes each other swing back and forth endlessly, it seems. That's the same kinetic energy that goes into the tissues. Now, let's say if you have, like I mentioned before, those adhesions or scar tissue buildups, this is great for purposely damaging the tissues targeted to the scar tissues. You put that on there and you have an application of, let's say, 2 minutes, you apply 2,000 shocks, you can actually destroy some of that scar tissue in a controlled manner. It's very effective. So when I say, oh, I dig my thumbs into somebody, I could also use shockwave. Depends on the area. When something's really, really chronic, like a chronic tendonitis, more so if it's chronic, it'd be a tendinosis technically, where a tendonitis is a really inflamed tendon. If it's been a long time and it still hasn't healed right, it becomes scarred and thick and irregular, and the muscle fibers aren't aligned as they were. You have to do something like shockwave therapy to literally destroy the tissue so it heals better, gives it another chance. Now, above this image.
Sorry, I have a quick question for you.
Yeah, sure.
And then I'm going to open it up to see if there's any other questions too. But so would this then work for somebody who was in a bad car accident, let's say, and have, it's actually a client of mine, and he has lots of scar tissue in his shoulder, and he did a lot of damage to his arm. So he's had a few surgeries on his arm he's gone to trauma for. So would shockwave therapy be good for him to get rid of the scar tissue? Because he does have a lot of scar tissue in his back, and he's always complaining about how, he's got headaches and stuff because he's always really tight in the shoulders, right? But there's a lot of trauma that happens there.
It very well could be an awesome treatment approach, just so that, like, the only real contraindication to this is anyone on anticoagulant medicine, anything where your blood clotting could be you know what I mean, compromised. Because with the nature of what it is, that you're literally, it's called shockwave, but it's not shocking. It's kinetic energy. It's like you're slapping the tissue over and over and over. Someone could hemorrhage if they're on that medication, but otherwise it could be great as long as there's no nerve damage. I don't see why not. I would, for my opinion here, I would actually start off with the neurology stuff first, just to see what I can get without having to address the hardware. See what we got, whatever we can't get from there. Then we go into the hardware stuff. Then you start seeing the body going through different patterns. They probably come back in a week being like, it's weird, my back hurts, now my neck hurts. What did you do?
No, absolutely.
In reality, that's really a good thing, because the motor control shifted. So if whatever was a problem now isn't, now we're going to go to the next problem. It's very, very fascinating, actually.
Yeah, absolutely. Absolutely. Is there any other questions while I, butted in here to ask that question? Is there any other questions from anybody on the phone?
Yeah, if you don't stop me, I'm like a train. You can't stop me.
No, you're passionate about what you do. And I wish that people could see you in person too and do some of the real live examples that you do, because it was.
See, that's where the magic is. Yeah, I talk all this stuff. The proof is in the pudding, really.
Incredible.
It's really cool. Yeah.
I will say this though, that you do have some really cool videos out there. So for those of you on the phone, certainly make sure that you check out some of the videos that Ricky has on R3 Integrative Health as well too, because he does do some demonstrations on that one.
Yeah, no, I have a YouTube video, and it's a 15-minute video. It's a complete patient visit. Actually, there's this person who came on. They were willing to, sign their rights away to go on YouTube, and never met him before. And I performed a 15-minute treatment on him, and it's a perfect example of all the stuff I do.
Yeah,
just on YouTube. You just put R3 Health Moncton, and you'll find it. It's right there.
Perfect. Thanks, Ricky. I'll make sure I throw that out on my Facebook page as well too, because it's quite interesting, some of the stuff you do. I mean, I've gone to osteopaths and chiropractors and stuff through the years too, but the addition that you add is quite interesting.
Yeah, there's a complete other layer, right?
Absolutely. Yeah. Mm-hmm. All right. I don't think we have any questions, so you can keep going. Sorry. Thank you for letting me interrupt.
Oh. No problem. Anytime. Just stop me. Okay, now the image on the top right now, we're talking about the bottom right one. This is called the cumulative injury cycle. Now, this entire chart, this scheme, this format of information was actually coined by Dr. Mike Leahy. I believe his name's Mike. Chiropractor. He developed active release techniques. It's a technique for manual therapy, soft tissue. So what he noticed throughout practice was people had, let's start here. I'm going to grab my laser pointer again. People started off with altered neuromuscular control, right? Or muscle imbalance, or adhesions developed, or muscle spasm or inflammation. Usually how it starts is tissue trauma. Something happened. Let's use the ankle sprain again. Tissue trauma. Okay, you sprain your ankle, you damage some tissues. Okay, brain recognizes that. Oh crap, we have to heal this. Sends inflammation, which is a bunch of blood, a bunch of proliferation proteins, all kinds of stuff to try and heal it again. That's usually where it hurts. It's throbbing, it's swollen. That's where you get that swollen ankle after a bad ankle sprain. Then you get some muscle spasm. If you sprain a joint, your brain's going to not want it to move. You're going to spasm the muscles. That makes sense. Now, fast forward 6 months, nothing happened. The adhesions will form. That's where, if you don't move it early on, you have more chances of developing adhesions, right? Then you get altered neuromuscular control. So it's chicken or the egg once again, where people of different walks of this profession, they say, okay, adhesions came first, and that's why you have a software issue. Okay. It could be also the opposite. I've seen it where it's altered neuromuscular control, and it's affecting body areas where they spasm, and then it develops adhesions. And then that causes altered neuromuscular control, and that causes another injury, and that causes, inflammation, muscle spasm, the entire thing. So it could happen of any part of this circle. It doesn't have to be one train of thought or one, you know what I mean? There's not one way it can happen. There's many ways. It's all possible. So I try to, again, have as many tools in the toolbox. Again, this is another example pointing back to what I was just saying. There's so many ways, right? So in PDTR, we also dive into emotional corrections. It's not psychotherapy. It's not like, psychology work or anything. Down here, just to clarify, NLP stands for neuro-linguistic programming. That is a technique for addressing these things here, all these eye vectors. These are eyeballs. These are different directions you can look in. So this would be up and to the right, up and to the left, down to the right, down to the left, right, left, right? So this is as if you're looking at someone in the face. This would be the right eyeball. Neuro-linguistic programming, these are actually that's actually drawn from that method right there. Now, PDTR utilizes their approach, their method, their technique, their correction format, and applies these same vectors to achieve a result their way, using their stuff, right? So that's kind of streamlining all the stuff that's out there. This is actually a part of applied kinesiology, I believe, and they're actually streamlining it to make it easier. So emotional corrections. Now, you may have something traumatizing that may have happened, right? and then that resulted in tension being built up, let's say in your neck, right? There may be a trigger there associated to it. So in this particular scenario, this slide is usually up when I do a demonstration, a live demonstration, doing muscle testing on somebody. And this is the woo-woo stuff where people usually check out. All the evidence-based people check out of this one. In my opinion, there's no way to kind of prove it in an evidence-based fashion because it's so subjective. There's so many things going on. But in my experience, my practice, it gives me so much information that I can't not do this. There's so much stuff. So let's give an example. Just not a real life example, just kind of a made up scenario. Let's say we look up and to the left, and I'm testing an arm over here, just a muscle that's not related to anything. I'm trying to see if it's strong. It's strong, let's say. And then I get the person to look up and to the left, and then all of a sudden their muscle over here, their arm pushing upward, is weak. Okay, I have to discern if they're looking up in a way that's dysfunctional because of eye muscles. Is it because they're actually looking at a really bad problem in their body? That's possible. That makes their whole body weak. That's actually a reflex pathway to the brain that if we look at a trauma site, our muscles will go weak in response to inhibit. Or is it just a visually remembered direction? So if you look up and to the left, you may actually look at a dysfunction, not actually look at a dysfunction, but it may be a trigger to a visually remembered event. Let's say, let's say you saw a bird get hit by a car and that really disturbed you. That's a visually remembered experience. Versus on the other side, on the right-hand side, visually constructed would be imagining a bird getting hit by a car, and that would be a trigger. Versus happening and you remembered it, it's actually in your memory, stored memory. And then auditory remember would be just sound. Auditory internal, which would be like, this is another category. It'd be like internal dialogue, things you say to yourself every day. That would be an actual trigger to a certain dysfunction, an emotional dysfunction. That gets into many different categories. As you see, I can go down the rabbit hole for hours here. Kinesthetic, imagining sensations like not remembering because it's on this side, imagining what it would feel like for your muscle to tear in your calf. That freaks people out. Sometimes some people have a general fear of, let's say, their neck. Let's say if they felt like a crack in their neck when they moved their head. Just thinking about their neck breaking or something like that, that would be a kinesthetic imagination. That would be a trigger to, let's say, rev up their nervous system in a way that's dysfunctional. But there's no harm necessarily, but it's traumatizing and it creates a dysfunction. So if they look down to the right, let's say, their muscles will go weak in response to that. Now back up here to this one. Let's say the bird got hit by a car. You look up here, then you get the muscle test to go weak here. And then what you do from there is, if you want to confirm that that actually is an emotional problem, what you do is you have the patient actually touch their forehead with the opposite hand. You confirm, it's called a Bennett point, and all you do is, again, take a couple fingers or your whole hand, put it across your forehead, and that should negate the weakness here. That arm goes from weak, looking up in that direction, to strong. Person still looking up in that direction, they touch their forehead. You know we have an actual emotional correction to do. And I'm not going to explain the emotional correction. I would actually do that on video, which would be probably for another time. But it gets really interesting, and you can either you can do it this way, or I have different ways that I've learned or developed, kind of in between, to where you don't actually have to have someone relive something. You don't have to have someone actually think about something or visualize something or remember. You don't have to do that. Sometimes you open up a can of worms in the practice, but you can really get some really high level, high priority problems really resolved this way, because a lot of pain is emotionally rooted. A lot of things, a lot of chronic pain, especially where perhaps they tie their pain into, there's so many things that happen because let's say they had pain for 6 years. A lot of stuff happens in 6 years. Perhaps they identify with their pain and there's a trigger whenever they see the color yellow. Perhaps that's pretty random. That's a pretty specific. That's a pretty specific example, but you never know, right? So there's a lot of different triggers to why pain can be there. So again, this is just going over emotional dysfunctions. So they all have their source in the subconscious mind, right? So it has many advantages over the conscious mind, like perfect memory. But the subconscious is actually unable to criticize or establish the relative importance of the information it receives. So what this is saying here is we're working on a subconscious level. It's not stuff that you are consciously aware of. You may not be understanding that if you look at the color yellow, your whole body goes weak. You don't really feel that. You don't really collect that. But it's actually happening on a subconscious level. So most psychological treatment consists of pulling the information from the subconscious mind, and it allows the conscious mind to kind of look at it and criticize and compare it. That's what psychotherapy is in general. That's kind of what we do when we give coping strategies and all the above to deal with that. Again, this is not psychotherapy. I'm just kind of reiterating what the subconscious mind is and how psychological treatment, official psychological treatment, is actually doing it. I'm sure there are other ways. I'm no expert in that, but for a general kind of explanation, that's what it is. So now we're going to get into priority of the nervous system. I briefly mentioned this when I said emotional dysfunctions can be good for correcting an emotional problem or emotional correction. So correcting, that's terrible. Correcting an emotional problem can resolve a lot of things because a lot of the times they're high in priority in the nervous system. By priority, I mean it's very, very up there on. It's very important to the nervous system. It's one of the very first things that will keep a pattern there. And what I mean by pattern is a compensation pattern. Let's say, again, let's take the lower back example that I initially took. And what we're going to do is we're going to take that lower back example, and the lower back was weak. Let's say all those muscles in the back were weak. And perhaps it happened at a time where the person was attacked. Well, the fact that they were attacked, there is emotional repercussions there because they were attacked. Perhaps it affects their subconscious mind or even their conscious mind, but in the subconscious mind, the fact of being attacked will kind of take whatever emotional aspect it affected and tie itself to the experience of the pain. Now, there might be traumas associated with people getting attacked. There might be things with you getting attacked, triggering your lower back pain that you haven't experienced in a long time. There could be different aspects there. So there could be a high priority there, right? Again, so more in general, priority in the nervous system is, it's usually, if you look at all the patterns, they're all there to balance something out. So once again, looking at why the brain is doing something. Why is the body doing this? Okay, you have to kind of find a problem. That's your end to the problem. Okay, lower back muscles are weak. Great. You go and you touch their cranium, and it's actually all coming from a misalignment of their occipital bone, the bone in the very back of your head. Let's say, for example, that's actually pretty common. You touch that. As soon as the patient touches that, their lower back muscles light up again, as if they were normal. You let it go, they go weak again. You know there's something there, right? And there are protocols within PDTR and functional neurology on how to establish what is quote unquote priority or quote unquote non-priority. So if you find something, let's say something like the lower back, once again, I'm going to stick with the same example. You find those lower back muscles that are weak. Let's go with the example of, okay, it could be a hardware issue. And on this patient, okay, there could be actual adhesions in the lower back muscles inhibiting them. Sure, that's totally possible. It probably is there since those muscles have been, locked up and tight for so long. Let's say you release those lower back muscles. Great. The person feels immediately awesome because you just relieve the tension where the actual tension, you relieve the tension where the tension is. And the person feels great. They walk off, and you don't see them for a while because they feel great. And then it comes back in a few weeks or a month or whatever, whenever they have either they do too much or there's a trigger or there's something else because the actual root or the priority dysfunction wasn't actually addressed. Whereas let's say the cranium is the priority in this case, you address what's going on in that occipital bone up at the top of the cranium, and then that problem never occurs again if it's actually the priority, which is the priority dysfunction in the cranium where the lower back muscles, they were just weak and tight to compensate and balance out that original problem that is much more important in the cranium. It doesn't always have to be the cranium, but this is a really common example. Maybe someone fell and hit their head, and then the lower back muscles went really tight and weak to try and protect the skull. Who knows? There's so many ways that the brain will kind of form these patterns and protect the human being. It's all there for a reason, but you kind of have to decipher that and work up the chain of priority. And again, the PDTR protocols, they kind of show you how to assess that priority and get there. So many other patterns, like what I just said, the lower back, they're called fractals. So they're like little pieces that fell off of the mother dysfunction, and they only exist to balance out that number one problem. So that's kind of what priority is in the nervous system, and it shows up in many different forms. It doesn't have to be musculoskeletal in nature. It could be an organ problem. It could be a thyroid issue. That, you know, once again, a thyroid issue that can't be managed with manual therapy. That could be, you know, chemically managed or surgically or whatever. That's a different kind of aspect, right? It doesn't always have to be conservatively managed. You can have an actual, you can have lower back pain, but the really root cause of it is their liver's failing, let's say. And that's a poor example, but it could be an actual organ failure, and that's why they're in your office. You got to know the difference. So there could be many different presentations, but as much as possible, try to get to the root cause, right? So that's what the priority means. So that's where functional neurology becomes so powerful, is because you can consistently find what is the top worst thing in the nervous system at any given point. So you don't have to try and retrace things. You don't have to, you can know that you send a patient off after a treatment and you know you've addressed the highest priority. And when you ask that question there, oops, I'm gonna go back. Getting too carried away here. When you ask that question regarding, what was I gonna say there? When you ask the question regarding, oh, you lost me. What was your question again, if you don't mind?
When I was talking about if the blaster would work for a gentleman that had a bad car accident.
The blaster, yes. The bad car accident, yes. So if there's structure governing the hardware, hardware governing the software, there's a lot of discussion on, there's different professions that kind of argue back and forth. Now you can see this from a sort of biased standpoint where, let's say, let me give an example, and then this is by no means pointing people out. This is a generalization. Let's say chiropractor will say, okay, it's the bones. You got to move the bones and everything will follow suit. Osteopathy and chiropractors, they a lot of them think that way. Not all of them, but a lot of them think that way. And then you get massage therapists, physical therapists. They're like, okay, it's the soft tissues and movement that has to be addressed. You know what I mean? I'm kind of butchering that generalization, but there's differences. Some people may say, okay, it's the hardware. No, it's the software. It's muscles pulling on the bones. It's this and that. Some people only treat adhesions and muscles. It's everything. It's always different. And if you limit yourself to one train of thought, and this is my opinion altogether, is if you limit yourself to one potential train of thought, it shows that either you don't know what's actually happening with your patients when they actually leave your office, if they actually got better. Maybe they didn't get better. You think they did, and they just ended up in someone's office because you didn't address everything properly. Or they're not being honest with you, or, you know what I mean? Maybe you are excellent, but you can't address everything with a cookie cutter method. There's just so many people out there. Every single person is different. Every single person is going to present differently. So 3 people have the same problem, and they might come in with 3 very different complaints. So there's so many different things here. That's why the functional neurology, once again, it helps you find what is actually the root, what is actually coming from. You might actually find that, you might actually find where someone's having bad elbow pain, but it actually came from an old collarbone break when they were 6 years old, and they're 40 years old. They'll look at you and they'll be like, okay, it's hard to believe what you're saying. I'll trust you because you're in charge here, but that's hard to believe. And then you do your treatment and your intervention, your manipulation, whatever, and they're like, I don't believe it, but my elbow is feeling better. This is weird. It's just coming from an instability at the shoulder. You just got to give them some exercises, correct the software, and there you go, and address a few adhesions that developed in the forearms that compensated for that instability of the shoulder, et cetera, et cetera, et cetera. So there's like kind of a domino effect happening there. Mm-hmm. So at this point of the presentation, and I forgot my past point that I was actually trying to retrieve. I might get back to it. I don't know. But at this point, are there any questions that form based on anything I said or anything I perhaps didn't say? I'll give you a few seconds there just to get some, if there are any.
Yeah, and Ricky, I want to ask the audience too if they're seeing your presentation all kind of broken up on the screen. I did ask earlier, I didn't get a response, but I'm thinking either it might be my download speeds or something. Yeah, no, Jessica's saying that it's broken on her end as well too. So can you like flip through it, Ricky, and then come back to it? Because there was some spots where it was garbled like that through the presentation. Oh, I know. Some of them are, some of them aren't. Yep. So go forward.
Let's go forward. This one might just be.
Yeah, we see like something in the nervous system. Then you see a half of a picture. You see the.
Oh, that's okay.
Yeah.
This actual slide. There's some. You see the colors in the very middle. You see different charts there. They're all reference charts because I don't know them by heart. There's a lot of them that are like really.
Yeah, but the reference charts we don't see fully though, Ricky. They're all broken out.
Oh, yeah, that's fine. This was just like a slide in passing that I was going to stop on for a second just to talk. But do you guys see this one clearly? You know, you can see that that's a pelvis.
Nope, it's broken up. It's got parts from the last emotions from Louise Hay. Wait. I'll go back. You were clear for just a second. No.
It might take a couple seconds.
Yeah, maybe. Now, I do know that we are at the top of the hour as well, too. So if there are people on the call that need to drop, we understand. This will be sent out. You're almost done anyways, Ricky, it looks
like. I am done the presentation anyway. Yeah, the last thing was priority. And then, believe it or not, the last slides were just anatomy posters just to do some presentations, some demos.
Nice. I wish we could do the demos, but for everybody that's on the call, please check out Ricky's YouTube, please, because I'm telling you, when I watched him right there early in March and what he did in the audience was absolutely astounding. And again, I've gone to, you know, a lot of people throughout the years for natural health reasons, and what Ricky was able to do in that audience with some of the things that I seen was just absolutely mind-blowing. So please check out his video, certainly worth it. And so Ricky, how do people get in touch with you? So R3 Integrative Health, that is Instagram, Facebook, and YouTube?
Mm-hmm. Yeah, R3 Health Moncton on Instagram. Okay. And you could just look up R3 Health in Google. I'll come up for sure. R3health.ca is my website. And then you can email me. It's Ricky, RICKI, @r3health.ca.
Perfect.
That's the easiest way to find me.
Excellent.
I appreciate everyone watching. That's it's great. I love talking about this stuff. And again, I can go on for hours. I can't be stopped once I start.
You are passionate, and that's what I loved about your presentation that night, and being able to, you know.
Well, it fires me up. Yeah, being able to be in front of people and show them this cool stuff is just, it's a dream.
Listen, I can't wait till you open up because I'm coming to see you as well too. So
come on in. Let's do the weird stuff.
Listen, I was in an accident. I was 6 years old. I was run over by a pulp truck. So I can't wait for you to work on me. So
there's probably many things. Yeah, probably many things there. Yeah.
No doubt. Anyways, thank you all for joining tonight. This video will be up. I'll send it out to everyone who registered, and it'll be up on the Facebook page as well. So thank you all so much. Ricky, thanks so much for your time. You're doing amazing work. I can't wait to keep promoting you because what you do is fantastic. So thank you.
Thank you very much. Thank you for having me, Catherine. Have a good night. Thank you.
Bye, everybody.